Thank you so much for being here this morning. This is our second presentation on serving patients who are experiencing homelessness. And we are very excited to welcome Dan Fifield with us today. Dan is a former ER nurse, and he is the co-founder and president of The Landing, which is a nonprofit that supports individuals in the Rochester area. And he's going to talk to us about building trust and establishing rapport when we're working with this patient population.
Thanks, Grace. Good afternoon, everybody. As Grace said, my name is Dan Fifield. I am the co-founder of The Landing, and then we're a nonprofit here in Rochester, Minnesota that works with those folks that are experiencing homelessness. I'll give you a real quick, brief history of how we got started doing this. I was an ER nurse. I was a Mayo ER nurse. Prior to that, I worked in Kansas City, Missouri at Truman Medical Center. And then after my few years at Mayo, I went over to the other local hospital here in town to continue my ER nursing career. It was my retirement plan. Little did I know that I was going to run into a family of 5 that were living in a Dodge Neon with a dog and a cat the week before Thanksgiving in 2018. And my actions at the time were to try and find them housing. I didn't think that I was going to be suspended for a couple of shifts because of what I did. I made a couple of phone calls. Another nurse said I gave him my personal contact information, which I didn't. But I was suspended anyway. My job was threatened. And my wife, Holly, and I decided that it was time to take that leap of faith and take care of these folks. I left my ER nursing career, which was my dream job, thought that that was the end-all cure-all, to take care of these individuals that are on the streets, that are struggling, and try and help them find that place that they need to go to. Our tagline at The Landing is to give everybody a soft place to land, and that's what we try and do. So one of the biggest things that we found in doing this is you have to develop that relationship, build that trust. And when you work with individuals that are experiencing homelessness, you have to understand that it's not something that they wanted. It's not something that they've looked for to do. It's not like everybody grows up and says, I want to be homeless. It's because of histories of abuse, dysfunction in families, bad decisions in social groups, mental health issues, paranoia, schizophrenia, and just flat not feeling like they can achieve anything. We have a lot of individuals that we work with on a daily basis that have no self-worth because of the way they've been treated in the past. They don't feel like they can achieve a thing. And it's hard. You have to understand that a lot of these individuals have nothing to work with or work from. They don't have ID. They don't have an address where they can send information to. They don't have a phone that they can get phone calls on. Even if they do, a lot of the times their phones get stolen, their ID gets stolen, everything that they own gets stolen, and then they have nothing. So they just continue to spiral downhill. And it's important that they find that place, whether it's in a hospital setting or in a nonprofit setting such as ours, that they can find somebody that cares, somebody that will sit and listen to them. The biggest thing that we can do as medical professionals or as just human beings is listen to somebody. If we don't listen, we don't know what the problem is. If we don't listen, we don't know what they want. It's crucial to not try and tell them what to do, but to ask them what it is they want to do in developing those relationships. Mental health issues, the paranoia and schizophrenia is rampant in this population. And it's quite honestly a very tough one to deal with when you're trying to help them negotiate a path to success. We got there's in Rochester as it is, there's mental health treatment facilities, but it's hard to get people into. It's hard to get people in on the timely manner. It's difficult to get them and keep them on medications. So it's a lot of work to keep on top of these individuals to make sure that they're trying to do what they can to help themselves, and we're here to help them. As I said, it's their lack of self-worth and their feeling of worthlessness is huge. They try and do something. They try and get an apartment. Well, past history, let them get an apartment. What do you do then, kind of thing? And that goes into the system failures and lack of follow through. There are a lot of resources that are available out there, but it's trying to connect the dots. These individuals, when we started The Landing, my analogy for folks, and try and follow me, a bicycle hub. The center hub on the bicycle wheel is the landing. The spokes that are coming out are the folks that are experiencing homelessness, and the outside rim are all of the services that are available out there. They're available in Rochester. I'm sure they're available in every other major city across the country, but it's how do you connect these individuals to those services? You do it by gaining their trust. You do it by making sure they understand that you're here for them and you're not here for any other reason. Try and help them understand that you're here to help them. Let them answer your questions. Don't try and answer them for them. But the system failures and the lack of follow through are a huge part of that issue. We try and set up systems where we don't have those failures here. We try and get releases signed so that we can talk to the medical professionals that are helping them deal with their mental health or their health problems. A lot of times we aren't able to get that, so it's a little bit harder for us, but we try and do the follow through. I've got story after story of individuals that have been discharged from hospital settings without proper medications, with not understanding what it is they're supposed to do as far as follow-up. One gentleman, the biggest payday I ever got was when I got Richard settled in his new apartment. He told me that nobody's ever cared about him like I do. That made it all worthwhile for me, but he had right lower extremity cellulitis. He had an open wound. He was in the ICU for multiple days. I was discharged without any medications. And the reason he was discharged is there was a $628 copay that he couldn't afford, but it was a simple problem to take care of. A pharmacy tech solved it for me. He got his Medicare in line with where it was supposed to be, and the $620 copay went to $27, which we were more than happy to pay. We got him his meds and got him into another facility for wound care and antibiotics, and all's well that ends well, but it's that follow through that they don't have the ability to do sometimes, that we have to work with, trying to get that taken care of. Next thing, what are the results of this distrust? Our homeless population that we work with is very distrustful. They've gotten a lot of false promises in the past. Yes, we'll get you housing, and they never get housing. Yes, we'll help you get medical care. They never have gotten that. And the list goes on and on. And that, that's multifaceted as far as where those trust issues come from. It's broken relationships, with family members. They've burned a lot of bridges, and it's the inability to create new connections and relationships because of their paranoia. A lot of their other mental health issues, physical and mental unwellness. We have a tremendous amount of the population has major medical problems. We've got one gentleman we're working with right now that's got some major tumor issues going on. I can't really get into too much more details because it's an active case, but he's very ill, and we're trying to help him negotiate through the system and make sure that all of his medical care gets taken care of. That's a part of it. Their medications are another part. They can't afford them. A lot of these individuals don't have jobs. They don't have income. They can't even afford, a $7 copay for a multitude of medicines. They just don't have the money. They can't qualify for GA. They don't know how to get government assistance. The list goes on and on as far as why those issues come up. Homelessness, that's a multitude of reasons for that, from mental illness, alcoholism, drug abuse, financial issues, relationship issues, things of that nature. We try and give them a place right now at the landing at Silver Lake Station here in Rochester. We just launched this new day center 2 weeks ago, today actually, with the help of the city and CARE Act funding. We give them that soft place to land. We give them a place to come and get meals three times a day, on a place just to be. We've got a director of social services that's on staff that takes care of their housing needs as far as getting them on coordinated entry, getting them set up with that type of thing. And we address the food insecurity problems. What are your major concerns? Well, if you're homeless, you want to know where you're going to sleep and where you're going to get your next meal at. We've addressed all of those issues. There's a warming shelter here in Rochester that's open in the evenings for them to sleep at. There's another facility where they can sleep as well. And we address it during the day here at the landing to give them a place to stay and get connected to those resources. So those things are important. They help them get back on their feet and going in the right direction. But the big thing is how do you build that trust? A lot of people want to tell these individuals what to do. Doesn't work well. They don't want to hear what you think they need to do. They want somebody to listen to them, because nobody does listen to them for the most part. We've been very successful in building these relationships, listening to what they have to say, asking them what they want. And sometimes they don't want to be off the streets. Sometimes this is a lifestyle that they've been doing for years and years and years, and they don't know any different. But It's listen. Just don't hear them. Listen to what they say, and then you just listen to them some more. You got to treat them like they're a normal human being, like they're no different than you are, like they're no different than anybody else that you meet on a daily. Because they're really not. They're just in a different set of circumstances. They've got problems that they're trying to deal with, just like everybody else does. Theirs are more visible because they, quite honestly, most of the time they don't look like you and I do. They're dirty. They haven't been able to shower. They haven't been able to do laundry. They've not had good dental care. They haven't had a haircut. People get just nasty with them. Why don't you get a job? Well, I love those people because I just like to set them down and say, let's look at it this way. You don't have ID, you can't get a job. If you don't have a phone, you can't receive phone calls to get the job. If you don't have a mailing address, you can't get a job. If you smell like you've been homeless for 2 weeks, you probably aren't going to get the job. And if you don't have access to new clothing or a way to wash your clothing, you're not going to get a job. So where do they start? What do they do from there? It's until somebody comes into their lives that's willing to help them, whether it's somebody in an ER setting, somebody on a medical floor, a social worker there, a doc that takes an interest in that patient beyond just their medical well-being, or an organization like us that takes that interest and wants to help them get back on their feet because that's the right thing to do. They don't. They sit there and spiral, and they may have had a great job before. They may have had things going for them, but things happen. COVID-19 happens. We lose our job, we lose our house. We're out on the streets. Our car gets impounded. We can't get into it. We don't have our ID. We're sleeping somewhere and somebody steals all of our stuff. We have nothing. It just happens. So, they're worried about meeting their basic needs. We think they need to get a job. We have to address those things that are more important to them than what we think. We have to address those basic needs. Make sure they have meals. Make sure that they have those things that they need to survive on a daily basis. It's being sober for a day, being sober for half a day. And a lot of these people is a big thing. And if you're involved with them, if you're working with them in the hospital, you have to understand that's the way that they've lived, that you have to not look down on them, but try and walk beside them and understand that they're trying. They just don't know really how or the best way to try, and they're looking for some guidance. Ask them meaningful questions. Ask them what they want to have happen. We have to celebrate those baby steps. We have to work with them through their timelines. Try and help them see that there is light at the end of that tunnel, that there is a better life ahead of them, and celebrate those baby steps with them. They say it's sometimes it takes 7 to 8 contacts to get something to work. And we found that to be the case. It's not a first time you're a winner kind of thing. So it takes time, it takes a lot of effort, but I tell you, when you get the successes, they're worth every penny of the time you spent. The beginning of relationship building for us started on the streets. We walked the skyways. I left my ER job. It was a Monday morning, a year ago tomorrow. We met with the social worker at the Salvation Army the following week and said, what do we need to do? And now that social worker who's at the Salvation Army is our director of social services and on our board of directors. So it's sort of a funny deal. But we had a big problem in Rochester with the folks that were homeless sleeping in the skyways. And we just went up there and we met them there and talked with them there and got to know who they were and what they needed and what we could do to help them. And we found the biggest thing that we could do getting started was to make sure that they had clean clothes, make sure they had food, make sure they had dry socks. We worked out of an SUV with tubs of clothing in there, and we built those relationships. We see people all the time that are living in tents under bridges, that are living in the woods, that are living off the bike paths, that are struggling, that are trying to find that bit of life that they don't know how to get to, and we try and help them negotiate to get there. And then we did mow. That was, we worked in an SUV. We looked for a building, tried to find a building to buy, tried to raise the money to do it. That was starting in November of last year. Couldn't get the building, couldn't get the money raised. And I had the vision of starting, buying the box truck and doing the outreach out of the back of that. We got the truck, got the branding on it. Alex and I hit the road, and 3 weeks later, COVID-19 hit and everything shut down except for us. We're an essential need. We're out there, we're able to social distance, we're able to build those relationships, continue to work with these individuals and gain their trust, and show them that somebody cares about them, somebody really does love them, and that works wonders when you try and make headway and get things done for this group, because nobody cares. Nobody else really wants to deal with them because they appear to be unkept, unwell, not good people. But in all honesty, they're probably some of the nicest people that we've ever met. You have to give them a chance. You have to give them an opportunity to be who they are. And you have to understand that they're sometimes not the most kind and not the most acceptable people in the world. But once you start peeling those layers back, peeling that onion back, you'll find that they're really decent, caring individuals that will back you up 110% of the time. So my words to you all, as you go out and start practicing medicine, you get on the floors, you get into the ERs, you get into the clinics, wherever you're working, is don't write them off as being homeless. Don't write them off as being worthless. Get to know them, talk to them, treat them like they're anybody else. Yeah, there are a lot of them that come into the ER that are drug seeking. There are a lot of them that are chronic alcoholics, and they're just mean and nasty as can be. But they're still human beings. They still have family somewhere that worries about them. They still have feelings. And if you can break through those, you'll gain a whole lot more than you're going to lose by doing that. So that's it. Now we're at the Landing Silver Lake Station. We launched 2 weeks ago with the help of the city of Rochester, some CARE Act funding. This is all a COVID response that we're doing right now, but we have a facility that we can hold 30-ish people during the course of the day, social distanced, offer them housing services, laundry, showers, clothing, food, and helping them get through some medical issues. That's what we do. It's been a blessing for us. And I just encourage you to, as you come across these individuals, give them a second to tell you their story, because I think you'll find that a lot of the times their stories aren't that much different than us. They've just taken a different turn on that road. So, give them a chance. Don't prejudge. Let them talk. And I think you'll find that your ability to care for them is going to be greatly enhanced. So, thanks for giving me the time. I can talk for hours about this. So, let the questions begin.
When discharging unsheltered patients from the ER, how can we balance our typical counseling of discharge paperwork and prescriptions and connecting them with services like you provide?
I think the big thing from the provider standpoint, it's tough because there's a line there. You're concerned about making sure they understand their meds, making sure what their discharge orders are. They're going to sit there and tell you they do, whether they do or not. The medications are probably one of the biggest things that they have problems with. You can give them scripts all day long, and you can send them to whatever pharmacy they say. If they don't have money to get them, it's a lost cause. It's a moot point for them. I think the thing that needs to happen, and a lot of times it doesn't, is to get social services, the social workers for whatever department you're in, involved with the care of this patient, to find out what those hurdles are for them. Especially if you get people that are coming in with any type of a cellulitis, extremities, because that's prevalent in this population, especially ones that are IV drug users. Making sure that they understand the importance of antibiotic therapy and things of that nature and what to watch out for. What we want to do and what we've tried to do is to get involved with discharge planning for these individuals, to make sure, because we know most of the folks here in Rochester anyway, make sure that they understand post-discharge what they need to do. And, if it's a medication issue, we don't have any problem with providing funds to get medications. That's not an issue. We want to make sure that their insurance is placed. We don't want to spend thousands and thousands of dollars on meds, but if, antibiotics are relatively inexpensive. We just need to make sure that they've got those. We need to make sure that they understand what the discharge follow-up plan is. So if you in your practice have social services that can and will get involved, or you can talk to your patient and say, we have XYZ organization here in town that can help you after you get out of the hospital. Would you mind us contacting them and getting them in touch with you? Whether you're here in Roch or wherever you are, I'm sure that there's probably some organization that you can get together with that would be more than happy to do that kind of thing. It's saving the hospital money, and that's sort of the track that I try and go down when I talk to people, is that, if you get bounce backs after, before 30 days out, your Medicare, Medicaid reimbursement, if they're on those types of insurance plans, you get dinged, you don't get your full payment. So what's better, making sure they're taken care of or not. So.
What are some of the challenges of getting people with criminal records jobs and finding them housing?
Housing is very difficult, especially in our area. There is not a lack of people looking for housing that have good, steady incomes with no past history. Trying to find felon-friendly landlords is tough. Trying to find landlords that will deal with anybody with any kind of a sex offense is next to impossible. It's very tough. It's very frustrating. One of our goals is to, somewhere down the road, is to have another location where we have a village, if you will, of small houses that will facilitate this population, because there are a lot of them out there that can't find housing because of past criminal history. The county has come up with a couple of different programs that help get these folks in. They guarantee some damage deposits and things like that, but there's still not enough. There are those individuals that are out there that are not actively seeking any kind of medical help as far as the mental health type of things, that need to be housed, that nobody will house because of that. They don't have any income. Stability is an issue for them. So it's hard. We just keep applying, and we keep applying. Say a lot of prayers, hoping that we can find people housing. Luckily over the last 16 months, we've got a large, not a large, but a increased number of shelter beds that have been open in the evening. The sad thing is, I have to say there's some good that came out of COVID-19. We've got an increase in shelter beds. We've got a day center now for these individuals to come to seek help. Hopefully after COVID-19 ends, if it ever does, or however that all washes out, we continue to have these services. But it's tough. There's no pat answer to your question. How do we get these people with criminal histories housing? Try and find a sympathetic landlord, or find a lot of money and build them yourself and work with them.
How does the experience of homelessness differ depending on where people are? What are the particular needs of someone in Rochester as opposed to Arizona or other places?
I think, if you get down to Arizona or Florida, it's a whole lot easier to be homeless, just from the simple standpoint that it's not freezing cold for the majority of the year. You can find outside areas that you can establish a camp in a little bit easier year-round than you can up here. When it gets 30 degrees below, a tent doesn't work real well. Sleeping bags can only protect you so much. I think in the bigger cities of Arizona and Florida, services are a little bit more prevalent as far as homeless shelters. We don't have a full-blown, what I would call homeless shelter. We've got what are called warming centers. Generally speaking, they're only open in the evenings. The one here in Rochester, the Rochester Community Warming Center, that's run by the county and Catholic Charities, it's open from 8 p to 8 a.m. What our vision is for a shelter is something that's open 24 hours a day, 7 days a week, 365 days a year, where they can sleep there, stay there, get medical attention there, things of that nature. So, that's our challenge here, is that we don't have that. We're trying to piecemeal it together with different organizations that offer different things, and it's difficult to get them connected to those different organizations at times. Open Door Mission in Omaha, Nebraska is sort of our role model. They've been in business since 1950, and they're probably the best homeless shelter I've ever encountered. They have a medical facility, they have a rehab facility, they have a low-income apartment building, they've got job training, they've got a women's shelter, they've got a family shelter. It's an all-inclusive, all-in-one, nobody's turned away at the door kind of place that I think every town of any size that has a homeless population should emulate, because it's successful. It hurts me deeply that we can't offer these individuals more solutions than what we do. A lot of these people would be very successful if they could get a chance. It's just being able to give them that chance. So,
how are you able to keep your empathy when you face so many challenges and it seems like your clients don't necessarily want your help?
Great question. It's tough. It is tough. It was tough when I was an ER nurse, because I saw those same people coming in daily for the same complaints. And sometimes you can't help somebody that doesn't want to be helped. And that's where the rub comes in. That's where the tough part comes in, because you really truly want to help them. A lot of these people, my goal is to keep them pink, warm, dry, and breathing. And if I can do that, I've been successful, because there are those individuals that don't believe that they can be any different than what they are. They don't care because they've been in this situation for so long. That's that's their world. That's the way it's been. I just have to try and look at it like it could happen to any of us, and it really could happen to any of us. Mental health disease, bipolar disorder is prevalent in 20s. We've seen it time and time again when we have families that they're all of a sudden they have a child that's been successful that is all of a sudden developed some very significant mental health disease in their 20s and early 30s, and it's difficult to deal with. But to answer your question, how do you keep the empathy? Just know that everything that you do has an impact, whether you see it or not. Every act of kindness will make an impact on them, and repetitive kindness is the best way to break those barriers. Those folks that come into your office or your ER and say, I can't survive without the big D, without the lot. I need that. Well, that's what they're so used to doing, and that's what they've been given for so many years or whatever. They get horribly frustrated. Or the chronic alcoholic that comes in and his liver panel's just whacked, and he's got varices that are about ready to break, and he's just a mess. Or he comes in and he starts blowing varices in your ER, because he won't make a difference. He's just broken. And from my perspective is, no matter how broken you are, you're still a human being, and I'm still going to care about it. And it's tough. It really sometimes, pardon my language, it just sucks. Because you want to do good for these people and they just don't care. Doesn't mean you have to stop caring. Doesn't mean that you can't, you stop giving your 110% to them. Because I promise you, one of these days when John comes in and sees you again for the 29th time this week with the same complaints, you're going to say something that's going to click with him, and it's going to stick. And you're going to have maybe this much of a gain in your plan of care and your treatment. But it's going to make a difference. And you'll see it, and you'll know it, and you'll walk out of there and you'll have the biggest smile on your face, and you'll go, wow, I finally broke through to this guy. Maybe just a little bit, but you still broke through. So, there's some people that I just assume give up on, but I just love my way through them, but with their behavior.
Guys, Dan, thank you again for joining us today, and thank you for all the work that you do.